Learning Plan 7 is the central nervous system. We're going to be talking about some psychotherapeutics that are natural to the body. We have amino acids, such as gamma aminobutyric acid, or GABA, and glutamate. We have cholinergics, such as antihistamines, monoamines, dopamine, serotonin, and epinephrine, and norepinephrine, and peptides, enkephalins, and substance P. Now, psychotherapeutics, the theory of emotional mental disorders is based upon the idea that some mental disorders are caused by an abnormal level of these endogenous chemicals within the brain. So to resolve that, we use different chemicals to help balance those levels. Let's talk about some definitions. Sedatives and hypnotics. A sedative is a drug that produces diminished responses to stimuli, but does not produce sleep. A hypnotic simply produces sleep. Now, can a sedative lead to sleep? Yes. But that's not the goal, and that's not the target. The sedative simply reduces reduces responses to stimuli, whereas a hypnotic simply goes to sleep. 5 stages of sleep cycle. These are important to know. Stage 1 is you're drifting. It's floating. Sudden muscle contractions are noted in stage 1. Stage 2 is generalized relaxation of muscles, very easy to awaken in stage 2. Stage 3 is extremely relaxed, difficult to awaken. Stage 4, decreased movements. You can be awakened, but you're very groggy or disoriented if awakened. The 5th stage is REM sleep, rapid eye movements. That's the dream cycle. REM sleep is the most important sleep for truly re-energizing, reinvigorating sleep. The ideal hypnotic will produce restful sleep, will not interrupt the natural sleep pattern, will allow REM sleep, will not have a hangover effect. That's the perfect medication. 4 types of medications for sedatives and hypnotics. Barbiturates. These suppress REM sleep and stages 3 and 4. So these are destructive to the normal sleep pattern. They're rarely used anymore for that reason. They're mostly used for anticonvulsants. They have a major hangover effect. They can cause paradoxical restlessness and excitability in elderly and the children. You can have a rebound phenomenon when you stop taking these. They have a major additive effect to other CNS depressants and alcohol. So you should not ever drink alcohol or use other CNS depressants with barbiturates. They're a Schedule II drug. High likelihood of addiction. Benzodiazepines are the next category. These also cause drowsiness and lethargy as an after effect, as a side effect the next day. They do have a hangover effect, although less than barbiturates. They can cause hypotension and respiratory depression. There can be physical and psychological dependence. They should never be used in a person with severe respiratory disorders such as COPD or asthma. Should not be used when pregnant. They also have an additive effect with alcohol and other CNS depressants. You must monitor vital signs. Assess for sleep apnea. Check the patient's age and assess for alcohol and other CNS depressant use. Monitor liver and renal functions. Remember what liver functions? What labs? Liver is ALT and AST. Renal is BUN and creatinine. Now, excuse me. The nice thing with the benzodiazepine is that if a patient were to get too much of the medication, we have a reversal agent. Much like with opioids, if you overdose on opioids, we can give you Narcan, or generic name is naloxone, and that reverses the opioids. With benzodiazepines, and only benzodiazepines, we have a medication called flumazenil. That's the generic. The brand name is Romazicon. Flumazenil is a benzodiazepine antagonist, and it reverses the effects of benzodiazepines. So that is a good thing to have on hand if you are in a facility using a lot of benzodiazepines. Now let's talk about non-barbiturates, non-hypnotics. I'm sorry, non-barbiturates, non-benzos. One of these would be Ambien. You see advertised on TV. Ambien's generic name is Zolpidem. This produces sleep. It has a very short half-life, so it must be given immediately before going to bed. It has minimal hangover effect, no rebound insomnia, does not interfere with REM sleep. It has a very short half-life. It does have an additive effect with alcohol and other CNS depressants. Psychotherapeutic agents for the three main emotional and mental disorders. Affective mood disorders, anxieties, and psychoses will be the next part of this review. Affective disorders include normal human emotions such as anxiety, grief, and depression, but when any of those expand to where they interfere with normal daily life, they become a disorder. How do we treat anxiety? We have 4 categories of medications: benzodiazepines, antihistamines, azapirones, and selective serotonin reuptake inhibitors. Benzos, we just talked about, they have that hangover effect. So the next day, the patient may have no anxiety, but may feel groggy, not themselves, a hangover. Azapirones, generic would be buspirone or Buspar. These are used for short-term treatment of anxiety. They are much less sedating than other anxiolytics. There's no additive effect on other CNS depressants, but do not use these with MAOI or MAO inhibitors or with grapefruit juice. Selective serotonin reuptake inhibitors. These are used for anxiety, obsessive compulsive disorder, and panic attacks especially, but also can be used for depression, bipolar, obesity, eating disorders, and actually as a smoking deterrent. Now let's talk about antidepressants specifically. MAOIs, tricyclics, and the SSRIs, SSNRIs. Excuse me. SSRIs, such as citalopram, Celexa, fluoxetine, Prozac, sertraline, Zoloft, and paroxetine, Paxil. These inhibit the reuptake of serotonin so that there's more serotonin floating between the neurons. It does not produce more serotonin. It simply allows that serotonin which your body has in a functioning form. These can be used as an antidepressant for decreasing anxiety, as a smoking deterrent, and also for eating disorders. In this case, they're used as an eating disorder to help the person gain weight. So if we think about what possible side effects might these medications have, selective serotonin and norepinephrine reuptake inhibitors, those are the SSNRIs, one of their side effects, a major side effect, is weight gain. Also, diarrhea, dry mouth, nausea, anorexia, sexual dysfunction, decreased libido, drowsiness, suicidal thoughts, insomnia, dizziness. Those are all causes of non-compliance. Even if you start feeling better, if you suddenly have diarrhea, dry mouth, sexual dysfunction, gaining weight, and have suicidal thoughts, are you going to want to take this medication? Probably not. So we always need to assess the person's state of mind, their level of consciousness before starting medications, while they're on medications, and throughout. We're going to assess for compliance. We're going to assess for rashes and any GI symptoms. We'll assess blood pressure before, during, and after therapy. Sexual dysfunction it needs to be monitored. Tricyclics. The key risk of the tricyclics is drowsiness, fatigue, and suicidal ideation. It's kind of amazing. You're giving an antidepressant to a person, and that medication actually triggers suicidal thoughts, but it does happen. So we need to monitor for that. We also have to monitor blood pressure and pulse for cardiac dysrhythmias. We have to monitor appetite, nutritional intake, and weight. Labs, CBC, liver functions, ALT, AST, and monitor glucose. This can affect the glucose levels. If a person overdoses on tricyclics, it's usually fatal 60% of the time. There are no reversal agents for tricyclics. You have to treat symptomatically: gastric lavage, activated charcoal, maintain respiratory and cardiac function, and use antiarrhythmics and anticonvulsants. It's not, a tricyclic overdose is not good. MAOIs, phenelzine, transcypramine, and isocarbazide. These inhibit the MAO enzyme in the CNS. It's used as the last drug classification to treat because of so many drug-drug and drug-food interactions. This is used only when people fail tricyclics, SSRIs, SSNRIs, and electroconvulsive therapy. So if none of those work, they put you on MAOIs. I mentioned drug-drug and drug-food interactions. This medication interacts with many foods in a very bad way, causing a hypertensive, potentially fatal crisis. So we need to watch out for high tyramine foods, beer, red wines, overripe figs and bananas, smoked and pickled and aged foods like canned meat, pickled foods, pepperoni, salamis, sausages, herring, sauerkraut, aged cheese, so a good aged Parmesan or aged cheddar, gravies and sauces that contain meat extracts. All of those foods can trigger a hypertensive crisis in your patient. So, if compliance is a major problem with this medication, because it requires such an altered lifestyle for some people. It also interacts with other antidepressants, decongestants, allergy and hay fever medication, opioids, weight reduction medications. So, very difficult medication to use. Now, if a person is on an MAOI and the doctors want to try another medication, you must give the person a washout period of 2 weeks. That means 2 weeks of no MAOIs, no nothing else, until you start a new medication for fear of triggering that hypertensive crisis. Some people use herbs for depression. St. John's wort has been shown to have a minimal effect on mild depression. But if you're taking St. John's wort and the doctor puts you on other medications, that can be a problem for interactions. So we want to use that very carefully. Mania, acute mania, labile moods, rapidly changing mood, flight of ideas, racing thoughts, loud, intrusive, angry, hostile, irritable, grandiose. We're going to treat those people with lithium. It alters transport within nerve and muscle. It's used for bipolar affective disorder. We need to watch out for some key side effects, though. Cardiac dysrhythmias, because lithium is very similar to potassium. Leukocytosis, or low white cell count. And muscle tremors and weakness, again, because lithium and potassium are so similar. If a person's dehydrated, this is a contraindication, as well as if they have severe cardiac or renal disease. If you're on medications such as diuretics or ACE inhibitors, lithium is not a good choice. Psychosis, major emotional disorder that impairs mental functions, such as schizophrenia. Now, for schizophrenia and psychoses, there are negative symptoms and positive symptoms. Negative symptoms are symptoms that take away. So, social withdrawal, apathy, poverty of speech, thought blocking, catatonia. It's taking away from a person's normal function. Positive symptoms add to a person's normal functions. So we're adding delusions, hallucinations, agitated, bizarre, impulsive behavior, combativeness, disorganized speech, disordered thinking. So negative symptoms and positive symptoms. And some medications work better on one than the other. Traditional antipsychotics, such as Thorazine and Mellaril, Haldol, those usually reduce positive symptoms. So a person who is combative and has hallucinations and delusions and agitated behavior, Thorazine, a traditional such as Thorazine or Haldol, will usually reduce those positive symptoms. It has significant anticholinergic and alpha-adrenergic blocking activity. It can also be used for intractable hiccups and at lower doses, nausea and vomiting. Has some major side effects. And among the most major side effects would be the acute extrapyramidal symptoms, such as dystonia, akathisia, akinesia, and bilateral fine tremors. Long-term, it can cause long-term extrapyramidal symptoms. Tardive dyskinesia, which is rolling tongue, lip smacking, athetoid, choreic movements, pelvic thrusting. You need to understand what extrapyramidal symptoms are and be able to identify those, because traditional antipsychotics are known for causing those side effects. It can also cause sleepiness, sedation, dry mouth, dry eyes, blurred vision. Remember, anticholinergic effects. It can cause orthostatic hypotension through the adrenergic blocking effects. It can cause weight gain. So we need to monitor for EPS and neuroleptic malignant syndrome when using traditional antipsychotics. Teach people to get up slowly. Avoid the sun because you can be very photosensitive. Avoid temperature extremes, so avoid the hot tubs and saunas. Now we have atypical or antipsychotics such as Risperdal, Zyprexa, Seroquel, Abilify. These are used mostly for improvement in negative symptoms. So if the person is not talking, if they're catatonic, if they're withdrawal, we'll give an atypical antipsychotic medication. It will usually improve social interaction and speech, usually. These block specific dopamine and serotonin receptors. They do have some alpha-adrenergic blocking and anticholinergic activity, some of the drugs. It can also these also can have EPS, extrapyramidal symptoms, and neuroleptic malignant syndromes. It can have a prolonged QT interval, which makes a person at greater risk of heart attacks. Weight gain, and it may worsen glucose control. Epilepsy. Epilepsy is excessive electrical discharge within the nerves of the cerebral cortex may result in seizures. What are some causes of seizures? Increased intracranial pressure, a CNS infection, fever. Those are called febrile seizures. Tumors or cysts within the CNS. Head trauma, withdrawal from barbiturates or alcohol, severe hypoxia, and hypoglycemia. The types of seizures, simple partial is consciousness is not impaired, going all the way up to the generalized convulsive seizures where loss of consciousness and total tonic-clonic seizures. Excuse me. We always want to assess, then do a neuro assessment. So we're going to do mental status, level of consciousness, seizure history. We're looking for drug allergies. We're going to look for cardiac, renal, liver function studies, CBC, and get baseline vital signs. We have a lot of medications to treat for anti-epileptic treatment. Most of these have a very narrow therapeutic index, meaning, remember that window of opportunity, very narrow. Below here, nothing works. Up here, it's toxic. This is where it works. Anti-epileptic drugs, the conventional, you cannot suddenly stop these or they will trigger seizures. So we're looking at things such as hydantoins and iminostilbenes, barbiturates, and the unspecified. You always need to continue these medications even after the seizures stop. They've stopped because you're taking the medications. You have not reversed the cause, you're simply controlling the seizures. These will all cause increased drowsiness. So, and you also need regular dosing, same time every day, because of that narrow therapeutic window. These are teratogenic and usually used only after 2 or more seizures. Barbiturates, we've covered these in the past. Phenobarbital is the most commonly used one in this situation. It's used for partial and generalized tonic-clonic seizures. It can also be used as prophylactic control of febrile seizures. Causes moderate sedation, drowsiness, and lethargy. Paradoxical restlessness in the elderly and the young. Hydantoins. Phenytoin is very common, as is fosphenytoin. These reduce spontaneous electrical impulses in the brain. These are used for generalized tonic-clonic and partial seizures. Some side effects: lethargy, abnormal movements, mental confusion, cognitive changes, and dizziness. Sound profound, but as the person learns to tolerate the drug, those symptoms do resolve over time. You should check phenytoin levels on a regular basis to ensure that therapeutic index is maintained. There are many drug interactions that increase and decrease the therapeutic effects, such as oral contraceptives, warfarin, and glucocorticoids. It can cause gingival hyperplasia, so we need good dental care if we're on hydantoins. The aminostilbenes, such as carbamazepine, these are used in conjunction with other anticonvulsants to control partial seizures. This can cause vertigo and visual disturbances and ataxia. It's also teratogenic. We need to watch for bone marrow suppression, so we're going to watch for leukopenia, anemia, and thrombocytopenia. We have valproates, or valproic acid is one of the medications. This increases that neurotransmitter GABA, and it's used alone or in conjunction with other anticonvulsants. As with other medications, many side effects: suicidal thoughts, sedation, confusion, visual disturbances. Hepatotoxicity is major with this one. Abdominal pain from the hepatotoxicity. Teratogenic. This increases the level of warfarin. Suxamides can be used. They have no idea why it works. It just works. It's used for treating absence seizures. It's sedating. It causes drowsiness and dizziness, leukopenia, and aplastic anemia. It has an additive effect with antihistamines, alcohol, analgesics, tranquilizers, other anticonvulsants, and sedatives and hypnotics. A lot of side effects, a lot of interactions there. Benzos. Most commonly used form is diazepam. And diazepam is the medication of choice in all forms of epilepsy and status epilepticus. Status epilepticus is a seizure that does not break after all other treatments. So it can be IV diazepam can be given for that. We've talked about all the side effects of benzodiazepines, and we've also talked that overdosing on benzodiazepines can be reversed with flumazenil. And then let's talk about Parkinson's quickly. Parkinson's disease, it's a neurological disorder characterized by muscle tremor and rigidity and lack of coordination. It's believed to be a neurotransmitter imbalance. We cannot cure it. We can only control symptoms. So we're going to use drugs to correct that imbalance. The drugs will not cause increased eating. So 5 types of medications to control Parkinson's. Dopamine agents are first. We want to try to reduce tremors and the rigidity. We can give straight dopamine, or we can give a combination, levodopa, carbidopa. Levodopa is the straight dopamine. Carbidopa, levodopa is a combination which has much better results because the carbidopa protects the levodopa and allows the levodopa to be absorbed into the brain. Using dopamine agents, we need to watch out for on-off phenomenon, orthostatic hypotension, palpitations, and darkening of the urine. The urine becomes very dark orange red. It can be very frightening at first. It's totally harmless. COMT inhibitors, such as tocapone and entacapone. So remember, capone would be COMT inhibitors. These prolong the duration of the levodopa benefit. So it relieves tremors and rigidity in Parkinson's, decreases the on-off phenomenon. Does cause some GI upset, urine discoloration, and it can increase dyskinesia. Tolcapone can cause severe liver failure. We monitor ALT, and AST for that. We have MAO-B inhibitors. This reduces the destruction of dopamine in the brain, allowing greater dopaminergic effect. So there's still dopamine in there, but it's not being broken down. This improves memory and motor speed. It has a neuroprotective effect by interfering with the degeneration of the dopaminergic neurons. Many side effects: hallucinations, dyskinesia, ataxia, orthostatic hypotension, tachycardia, dysrhythmias, dry mouth, extrapyramidal effects. You want to avoid concurrent use with SSRIs and tricyclics. You may need to increase hypertensive medications. We also have anticholinergic agents, such as benztropine mesylate and procyclidine hydrochloride. These are used to reduce hyperstimulation caused by excessive acetylcholine. Side effects of, well, what do anticholinergics do? Blurred vision, constipation, urinary retention, dry mouth, throat, and nose. Cause palpitations, arrhythmias, orthostatic hypotension, nightmares, confusion, hallucinations. Do not use with narrow angle glaucoma, prostatic hypertrophy, tardive dyskinesia, or myasthenia gravis. That's it for the CNS system.